So thank you so much for our respected chairpersons and the speakers for this very interesting and interactive session. So let's move on to the second session for the day, which is the second oral abstract presentation. So ladies and gentlemen, please join me to welcome the chairpersons for our second session. Dr. Mansoor Al-Smaili. Dr. Mansoor Al-Smaili is a consultant internist and rheumatologist at King Khalid University Medical City and Asir Central Hospital. He's also an assistant professor at College of Medicine at King Khalid University in Abha. Dr. Mansoor. The second chairperson for the session today is Dr. Muhammad Al-Sultan. Dr. Muhammad Al-Sultan is an internal medicine consultant as well as a rheumatology consultant, and he is also the head of the rheumatology unit and the program director of the Saudi Board of Internal Medicine and the Saudi Fellowship of Rheumatology at King Fahd Specialist Hospital in Buraydah. Please join me to welcome Dr. Muhammad Al-Sultan, Dr. Mansoor Al-Smaili to the stage. Thank you.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Walid. Welcome to this session, which will be about the oral abstract presentations. We have 4 abstracts will be presented by 3 speakers. The Q&A and the discussion will be at the end of all the presentations. We will start with the first speaker, Bashair Al-Qahtani. She's a PhD student working in the Zoology Department, College of Science, King Saud University. And her topic will be about the clinical, serological characteristics and delay of diagnosis in patients with the primary Sjogren syndrome in Saudi Arabia. Welcome, Bashair.
Bismillahirrahmanirrahim. It's my pleasure to present for you the first report on the clinical and serological characteristic of primary Sjogren syndrome patients in Saudi Arabia. We will start with a brief introduction, as we know that primary Sjogren syndrome is an autoimmune disease that characterized by lymphocytic infiltration of the exocrine glands, like the salivary glands and ocular glands, that leads to sicca symptoms and systematic inflammation. And it is the second most common systematic rheumatic disease after rheumatoid arthritis, with a female predominance. The patients of primary Sjogren syndrome can show 4 main symptoms. The first one will be dryness, where the patients can get ocular and oral dryness, and fatigue and systemic involvement that may include pulmonary involvement, and cutaneous involvement, and central or peripheral nervous system involvement. And the worst complication will be cancer. As shown by the Big Data Sjogren Project Consortium, which is an international multi-center registry that includes 20 centers from 5 different countries, that the primary Sjogren syndrome phenotype can be influenced by ethnicity. Until now, no studies has evaluated primary Sjogren syndrome in the Arabian Gulf region in the terms of diagnostic delay, disease characteristic, serological, and histopathological findings. So the aim of the present study is to describe the first primary Sjogren syndrome cohort in the Saudi Arabia. We recruited 41 patients of primary Sjogren syndrome and 71 healthy controls aged from 18 to 77 years old. This is a single center cross-sectional study, and the patients were recruited from rheumatology and pulmonary clinics in King Saud University Medical City in Riyadh. The clinical characteristic, laboratory investigations, and autoimmune profile were collected. The result shows that, as you can see in this table, that the table shows the demographic characteristic of the patients included in this study. We can see that that were a female predominance, since 78% of the participants were females, and the mean age for all the patients was 58 years old. Regarding the diagnostic delay, the main delay was only 2 years old, which is faster than many populations for too many reasons. The first one will be the early referral to both scleroderma spectrum disease and to interstitial lung disease specialized clinics. The second one will be the rapid access to minor salivary gland biopsies within only 2 weeks of referral from oral medication department. Also, the outcome measures showed that the disease activity index was 9.9, and it was higher in patients from pulmonary clinic since they got interstitial lung disease. And the mean of patients reported index was 5.17, and the mean of the patient's global assessment was 5.2, while the physician global assessment was 4.4. Regarding the autoantibody profile, as we can see that the anti-nuclear antibodies was positive in 78% of the patients, with a higher prevalence in patients from rheumatology clinic. Regarding the Sjogren's syndrome autoantibodies, we can see that both the type A and type B Sjogren's syndrome antibodies was positive in all the patients. Regarding the Sjogren's syndrome, type B was more prevalent in the patients, since 46% of the patients was positive to type A Sjogren's syndrome autoantibodies. And the rheumatoid factor also was positive in 24% of the patients. Regarding the extraglandular manifestation, the extraglandular manifestation was present in 87% of the patients. And all the patients identified in the pulmonary clinic has extraglandular manifestation in the form of interstitial lung disease with or without pulmonary hypertension. This figure shows that the result of the minor salivary gland biopsy. The minor salivary gland biopsy was performed in 38 patients, and 63% has a positive findings. And 37% of them has a focus score more than or equal to 3. Regarding the extraglandular manifestation, the most common extraglandular manifestation of our sample size was the articular and the pulmonary involvement, and followed by the central nervous system, peripheral nervous system involvement, and renal involvement, and thrombotic involvement. Conclusion. This is the first report on the clinical and serological characteristic of primary Sjogren's syndrome patients in the Arabian Gulf and in the Saudi Arabia. There was a diagnostic delay with a variable duration, and a national Saudi registry for Sjogren's syndrome needs to be established to better understand the disease phenotype, the response to medication, and the disease prognosis. Thank you.
Bismillah ar-Rahman ar-Rahim. It's my pleasure to introduce the second speaker, Dr. Mohammed Al-Umair. He is well known to us, associate consultant, associate professor in King Saud University. He has Saudi Board of Rheumatology and with subspecialty of rheumatoid arthritis and systemic sclerosis from University of Toronto, Canada. He is founding president of Charitable Association of Rheumatic Disease. Dr. Umair has more than 44 published reward articles. He will present two topics. The first topic, relationship between different anti-rheumatic drug therapy and complementary and alternative medicine in patients with rheumatoid arthritis, interview-based cross-sectional study. Welcome, Dr. Amir.
Assalamu alaikum wa rahmatullahi wa barakatuh. Again, on behalf of my colleague, Dr. Hayal Malak, who was not able to join us in this meeting, I'm going to present the project that she has been supervising her master student on use of complementary medicine in patients with rheumatoid arthritis. So let me just give you a brief on this project. So. Of course, the two papers has been already published in the Saudi Pharmaceutical Journal. They're open access, free online journals, so you can look at both of them. So I'm going to discuss the second paper, which is the relationship between different anti-rheumatic drugs therapies and complementary or alternative medicine and the relation of risk factors. So as you know, in our Saudi cultures, the use of complementary medicine or alternative medicine is very common due to the cultural reasons and even the holy scripts from the Quran. So many people use honey, use black seed, and other substances to improve their health as healthy people or to treat their illnesses. But the use of complementary medicine is much more inclusive just only of these natural substances. So multivitamins like vitamin D or B12, other supplements like omega-3 are all considered complementary medicine use. So the study was a multi-center cross-sectional study between King Saud University and Prince Sultan Medical City in Riyadh. This study included more than 400 patients initially, but then we did some subgroup analysis on less number of patients. Of course, female were predominant, and from my abstracts and some other abstracts, we don't really see the 75-25 ratio. We see a higher number, 80-85, between male and female. So this might be a sign of more female predominance of rheumatoid arthritis in Saudi Arabia compared to the other ethnicities. Now, why people use complementary medicine? As I told you, it might be due to cultural reasons, but also many people use it because they are not very satisfied of their disease activity condition or their general health condition, or because they want to prevent other diseases as they are growing old. So it's very complex. And from the first study, I think the first study has really changed my perspective as a consultant. I was somehow a little bit very aggressive with patients when they use complementary medicine, and I was always in a very scientific track with these patients. But the first paper has actually shown us that many patients are hiding what they are using from their physicians, and the main reason because they were afraid of the reaction of the physician. So now I'm more democratic and more open-minded to my patients, and I usually discuss with them that this is their choice, and just to advise them on what we really fear is that if they are using some substances that have unknown origin. So if a patient tells me, I want to take Yansun, for example, I have no problem. But a mixture from Attar, because some of these people mix their complementary medicine with steroids and other medications, so they make feel better. And some of them are using other substances that might be toxic to the patients or cause organ damage. And of course, complementary medicine is usually cheap unless you go to GNC. So we got ethical board approval. This is the study population. We have looked at demographics of patients, underlying medications, and this is the statistical analysis. I'm not going to go through that. Basically, we have found a younger, little bit age population in this study compared to the study we presented yesterday, with a mean age of 49. And 2/3 of the patients, exactly 2/3 of the patients are using some kind of complementary medicine. Now, female gender was associated with more use, disease duration, so being older, and the educational level. So the lower the educational level, the higher the chance of use of complementary medicine. And again, a mildly elevated ESR might be a risk factor. Now, unfortunately, because of this study was done from different clinics, we don't have disease activity measures. So we don't have DAS28 or SDI or CDI, because many rheumatologists who participated in the study do not usually do these outcome measures. Again, methotrexate is the most common DMARD, and many of the patients were on monotherapy, which might be a sign of well-established disease, well-controlled disease. When we did some logistic regression, we found that methotrexate, the use of biologics is associated with a less use of complementary medicine, and maybe because of the satisfaction of patients being on medication. We found some conflicting results about non-steroidals, but again, we cannot really interpret it clinically. Now here is the logistic regression. Again, disease duration, female gender, use of non-steroidal, and the biologics has all been associated with use of complementary medicine. Now, what we could take from this study is that not only complementary medicine is common, but some patients are more at risk of using complementary medicine. So what I really advise my colleagues is you have to always have this question in your mind in order to identify the type of complementary medicine, make sure that there is no scientific reason why not to use it, and then go on with the patient. Actually, the most common cause or reason why I advise my patients not to use complementary medicine, that it's expensive. Some of them use very fancy, expensive complementary medicine and of no added value or no scientific value, so I usually tell them, don't waste your money. With this, I would like to conclude. Thank you very much. Okay, my next abstract was actually a large study looking at different anti-inflammatory, pro-inflammatory cytokines, chemokines, and growth factors in a cohort of rheumatoid arthritis patients who actually were having mostly high activity disease. So we do not have any disclosure, and this is going to be my agenda. So basically, interleukin-10, and you have seen two outstanding presentations by our colleague immunologists about interleukin-10. So interleukin-10 is an anti-inflammatory cytokine that plays a role in the immune regulation As seen, its deficiency or defect will lead to increased activation of the anti-inflammatory aspect. Now, IL-10 is produced by different cells, but it is mainly produced by B regulatory cells, but also by other cells like T regulatory cells, macrophages, and others. Now, IL-10 also has an impact on different TH pathways, including TH1 and TH17 pathway. Now, it has been long thought of IL-10 as a potential target in managing patients with rheumatoid arthritis. The problem that they could not really know how to do it. In mouse models, if you infuse IL-10 into collagen-induced arthritis mouse model with active disease, whether you give it intraperitoneal, you give it in the blood, you give it in the paw, it actually causes improvement in the inflammation. Now, they tried in previous studies to infuse IL-10 in RA patients, but unfortunately, the preliminary clinical studies were negative. So in this study, we were exploring IL-10 level in our patients and look at the relation of IL-10 with patients' characteristics, with disease characteristics, and the underlying medication and the disease status. So this was a cross-sectional study evaluating IL-10, and the hypothesis is that we thought that patients who are on biologics have a more elevated IL-10 level because of their mechanism of action and the better disease control, regardless of the DAS, of course. This is the statistical analysis. Again, I'm not going to go through that because you have seen it in different abstracts. So we have recruited 78 patients. Again, you can see the female predominance, 85%, with an older disease duration of 47, older age, and a high disease duration of a mean of 7.4. Seropositivity was observed in 80%, and the mean DAS28 was 4.34. So this is a cohort that most of the patients were not having a well-controlled disease activity. Now, if you look at the IL-10 level, there was an increased IL-10 level in patients with RA compared to their age and sex match controls, while if you split patients into males and females, gender did not have an effect on IL-10 level. There was no correlation between the disease duration and the IL-10 level. And there was a signal toward double seropositive patients having a higher IL-10 level compared to the seronegative patients. And this could be confounded that patients with seropositive disease have a more aggressive disease compared to seronegative disease. And so maybe this is not a true phenomenon. If you look at the DAS28 status, patients with high disease activity have obviously a higher IL-10 level, while the patients on remission have a very low IL-10 level, very close to the normal value. But in the low and moderate level, there was no clear concordance between the IL-10 level and the disease activity. Again, this study was really guided by the sample size. If you had a more reflective number of patients in each disease status, that would be more obvious, or going to see a better sign. Background therapy, we saw that patients with biologics, of course, IL-10 level is higher than in RA patients compared to control, but you could see here that patients on biologics have double the IL-10 level compared to the patients on conventional DMARDs, regardless of disease activity, and this was not statistically significant. Then we run the panel of the pro-inflammatory and anti-inflammatory, and you can see that the IL-10 is beautifully correlating with all pro-inflammatory cytokines and the anti-inflammatory cytokines. So what we could learn is that maybe patients who are using biologics are inducing not only or blocking the anti-inflammatory pathway, but also are inducing are not only blocking the pro-inflammatory pathway, but are also inducing the anti-inflammatory pathway. And we have one of the oral abstract presentation by one of our trainees who showed that abatacept actually increase B-reg cells and the related cytokines. Now I'll take you to what is new and what could be a hope. And this study actually is a good help because we're gonna see when they're gonna look at patients who are going to these trials, if our patients fit this medication or not. So Decavil is a drug developed by a company called Philogen, which is actually a drug that has two components. It has an F8 antibody, which goes to the inflammatory sites only. So it's like a GPS that goes to the inflammatory sites and take IL-10 molecules with it. So the IL-10 that only goes to the inflammatory site, does not go anywhere else. And fortunately, Decavil has passed the phase 2 trial, just published in Annals of Rheumatic Disease, with positive results. So now it's going into a large phase 3 trial. Now, the limitation of our study, of course, the calculated sample size was not achieved because we had a problem in the funding, and the student who was supposed to do the study unfortunately dropped her project. And one important point that I wish we could really explore is that the serum level of IL-10 does not explain the full picture. So synovial level of IL-10 or even tissue level of IL-10 might also play a role in its anti-inflammatory effect. And maybe this is one of the reasons why we don't see this kind of concordance between inflammation and IL-10. So in conclusion, our study again proves that IL-10 plays an important role in the pathogenesis of RA. We have seen some signals on some factors that might be correlating with IL-10 level. And of course, a specific look at IL-10 level in patients achieving drug-free remission is also warranted. So we want to see if a patient is in drug-free remission, does his IL-10 level go back to normal? Thank you very much.